So now I'll invite Dr. RITU Aurora. She's an eminent cataract refractive surgeon from Delhi, always very ready to adapt and evolve with the newer technology. She also calls her teaching programs now LEAD, which is learn, evolve, apply, and discuss. So that's something to look forward to. Dr. Ritu.
Thank you so much. Uh, I'll be talking about managing post-op refractive surprises. It's definitely something that we don't look forward to. So we know refractive cataract surgery now, the patient's expectations are really sky high, and partly it's our own fault because we as doctors overpromise spectacle-free vision. So we are so much in competition with our, peers and neighbors that, we all like to tell the patient that you're not going to need glasses at all. So although the advances in technology, IOLs and machines, and much better understanding and assessment of biometry has helped us to get there, and almost, like I would say, most of us, 85%, are within plus minus 1 diopter, and 55% patients have been shown to be within zero point 0.5. But what we need to achieve, the target that we really need to achieve to hit the bullseye, is that 91% should be within zero point 0.5 and 100% of our patients should be within 1 diopter. So what do we understand by a refractive surprise? It's basically a failure to achieve the intended post-op refractive target. So that means when you're counseling the patient, discussing with the patient, you do come to target, what kind of refractive, do you want to leave them emetropic, or you want to have a little bit of myopia? So you are discussing that with the patient. So if there's any difference between what we have pre-op planned and the post-op result, and the error is say more than 1 diopter, we'd call it a refractive surprise. And basically the problem is that there becomes a gap between what the patient's expectations are and what the result is. Now, even a previously myopic patient whom you've counseled, who's gone for a monofocal lens and is 6'6", you think you've done an excellent job. The patient is very unhappy the next day because he can't look at his WhatsApp without his glasses, which he was used to earlier. So if you've not had that discussion with your patient preoperatively as to what they need to expect, such patients can be very unhappy. And multifocal lenses that we are trying to use, EDOFs and trifocals more and more, they are extremely sensitive to even small errors. So how do we manage these refractive surprises? Of course, the pre-op counseling I also already spoke about, and certain preventive measures, having a standard protocol, analyzing our cases and doing corrective steps then. So never promise spectacle-free vision. Always say that there'll be a reduced dependency on glasses, and always specify. I've started saying that it is dependent on machine measurements and individual healing. So I always tell my patients it depends on how your eye heals. Now, you can't promise them that each and every patient is going to be perfect, so it's better to put the onus on them. So I use that line very clearly, that it depends on the healing of your eye, and that no eye ever has a zero power. So you'll always have a little bit of 0.25 or cylinder or sphere. And fine tuning with glasses may be required. And sometimes I think now, we've got in our consent form also a line saying that glasses may be required after surgery. So taking preventive measures is extremely important, especially where you have risk factors. So those are those high hyperopic patients, high myopic patients. You have to be much more careful about your biometry. Repeat it, as was said by my previous speaker. Call them on another day. And do tell them also that, these machines are only estimating it. They're not 100% calculating. There's always, a little spherical deviation in your measurements. Treat the MGD, the dry eye, that can cause a lot of variation in your measurements. Ask them for a history of refractive surgery. And wherever you're thinking that there could be ectasias or dystrophies, or pentacam tomography is important. I end up doing a lot of vitrectomy, post-vitrectomized eyes, which have silicone oil. So again, you have to be very, very cautious in these cases, as you can have refractive errors. And long-term contact lens users, you need to ask them to stop discontinue their lenses before you do your biometry. And any patient who's an outlier, who has a very steep cornea, flat cornea, deep anterior chamber, and all of them, the formulas that we use, the effective lens positioning that we estimate goes a little wrong. So these cases again can be cases where you could have refractive errors. And of course, if you have a subluxated cataract, pseudo exfoliation cases, or you have a zonular dialysis per operatively, you see that. So again, that could be a risk factor. So the preventive measures would be doing a very accurate biometry, doing the biometry before you do any intervention. Optical is of course ideal, but if not, then immersion is equally good. And you must always measure both eyes. Even if the patient is pseudophakic in the other eye, always take both eye measurements and see if there's any difference in the axial length in both the eyes. So these are the conditions in which you would like to repeat your biometry, and always use two different methods if possible. So even if we are doing optical, we also do immersion. Or you can, if you have two, very lucky to have two optical biometers, then do it on two machines or on two separate visits. And a correct IOL selection using the right biometry formula depending on the axial length, depending on whether the patient has refractive surgery, using the online toric calculators. For me, Barrett Suite is my go-to for all cases, but I also use Hill RBF. I find both of them to be extremely accurate. Of course, there are many more newer formulas. If you have access to them, that's great. And then always select your refractive target, and this has to be with a discussion with the patient. So some lenses you need to choose the closest minus, and some lenses you would prefer to choose the closest plus. So another thing important is, of course, with our NABH, we've learned to have a surgical safety checklist and a timeout. You must confirm it's the correct patient. You could have two patients of the same name in your OR. It's the correct eye, because sometimes the patient you may have planned the right eye, but the patient feels his left eye is worse, and he may be telling your pre-operative assessment at the pre-op area, your technician, that no, it's this eye to be operated. So that should be confirmed. The correct IOL is available in your OR. And of course, you must also know your incision site and planning, and put up your toric IOL sheet. That should be displayed. Surgical perfection goes without saying. We are all excellent surgeons. But sometimes if you have very hard cataracts, you have a burn, you have overhydration also is a problem, or you have a leaky wound. Rexes has already been spoken about, and IOL centration has also been spoken about. Sometimes in small pupils, you may have an asymmetric haptic fixation. So always check that your haptics are both in the bag. And if you end up having a zonular dialysis, use a CTR, use capsule segments. In case you get a PCR unexpectedly, you can do a reverse optic capture. And of course, always remove the retained viscoelastic. So if you do have a problem, what do? You need to analyze. Sometimes you have such an obvious problem that on the first post-op day, you know something has gone wrong. Otherwise, if you do have some minor refractive error, you have to wait for 2 weeks for the refraction to stabilize, and do the refraction yourself. Look at the patient's records to see if there has been any error. Some data entry and error could have taken place. If the patient is unhappy, discuss the options. If not, if the patient is not complaining, manage the patient conservatively with glasses. Always do a dilated refraction, check your IOL position, look for capsular distension syndrome, look for any subtle corneal abnormalities that you may have missed. And of course, if you've not done an OCT, do a OCT post-operatively to look for any CME or any other, ERM or juxta telangiectasia, which could be a reason for a refractive surprise. But always hold the patient's hand, reassure the patient that you can provide a solution, because you must always let them feel it's a teamwork and that you're, with them. The patient will not go hopping, and you won't have other doctors telling them what went wrong in your surgery. So tell them that anything that happens can be solved, that the right time, the right cost has to be conveyed to them at the right time. So corrective steps should be taken depending on the magnitude of the error, the attitude of the patient. Patient could be happy, you could be unhappy. I remember I had one toric patient. I was unhappy because the patient had an error around 1 diopter. I corrected it, but the patient was still unhappy. Although, the post-op refraction was better to my satisfaction, But patient felt that no, whatever was done on the first time was, comfortable. So look at the status of the other eye. Suppose the patient is, you're doing a monofocal, suppose not even a premium, or you're doing an EDOF, and the patient has a little bit of a surprise. You could manage that in the other eye, and the patient could, with both eyes, be quite a satisfied patient. So always do a good refraction and repeat the biometry to see if there's been any error on that. So your correction could be cornea based. As we said, we could do a PRK, LASIK, or a femtokeratotomy. This is good if it's a small error, less than 4 diopters. Of course, for hyperopes, as we know, LASIK is not really very good. But the advantage is that if you have any higher order aberrations that can be corrected at the same time, it's also very safe in patients who come to you late, or if you're getting a patient from someone else's refractive surprise. The patient has already had a YAC capsulotomy. Of course, you don't want to go in and do an IOL exchange. Disadvantages are that there could be dry eye, it's additional cost, and you need to see the corneal thickness, of course, if the patient has had a refractive surgery earlier. The lens-based options would be an IOL exchange, a piggyback. We do have Indian lenses available from the care group called Sulcofix. You could also use phakic IOLs as a piggyback IOL. And in case you have toric lenses with a refractive surprise, then the astigmatismfix.com is the option. So these are good for large refractive errors. And in the early post-op period, the same wound can be used. It's less costly as you're doing it in your own facility. And there are no induced aberrations, no additional dry eye. So for IOL exchange, there are different options available. You can use these IOL cutting scissors. You can, cut it into 3 parts, or you can twist and turn and remove it. There are various methods. And the piggyback IOLs, of course, the advantage is that, your intervention is very minimal in such cases. So here I'll just show you one of my cases, who's a 65-year-old female who had MGD and allergy. So she had a relatively small pupil. Right eye, we did a EDOF lens, and we put in a 23.5. Unfortunately, there were 2 patients who had similar names. And the first day when I saw her, I was shocked to see that her vision was only 6/36, and she had a refractive surprise of plus 3.5 with a clear cornea. And when we checked our records, we found that 2 patients, Naseem, Fatima Bano, so that Fatima thing got mixed up and the wrong biometry sheet was attached. So we took up the patient for an IOL exchange. After 2 days, and we put in a 26.5 IOL from 23.5. So first you need to dial the haptics out. In such a case, use a good viscoelastic. Stabilize the lens from the side, because if you don't hold the lens with the microforceps, it's very difficult to cut these. So here I've cut it almost 90%, but you can even do half, and then you can dial it out, or you can cut it into 2 or 3 pieces and then remove the lens. So it's quite easy actually. These lenses are soft and you can get a very good result. So as I said, astigmatismfix.com is really a godsend for your toric lenses, and you can analyze, you can enter your post-op refractive data in that, and then you can compare what is the current location of your toric lens to what the patient's manifest refraction is, and then the analyzer would tell you whether rotating the lens would actually help. Not all toric lenses can be, the refractive surprise can be corrected just by lens rotation. So whether you want to rotate the lens or you want to do some other top-up procedure can be, better in such cases is to go for a LASIK or a PRK. And the second video that I'd like to share with you is this patient who was 60 years old, diabetic, and I'd already done a left eye toric for her. And right eye, I had planned a toric, which was a T4 IQ at 115 degrees. And on the first post-op day, the patient had a 6/18 vision with a refractive surprise at 15 degrees. So when we did the keratometry, I dilated the patient, and then to my surprise, this was the first time it ever occurred with me, was that the axis was at 15 instead of 115. So, I always make it a point to announce in the OT. The sheet is there, but I also announce to my assistant what is the lens alignment. But somehow my mind must have wandered away, and instead of marking 115, I marked 15. So, of course, this patient I took up the very next day, and this was very simple. I didn't put in any viscoelastic. I just opened up the side wound and realigned the lens. And we've already discussed in detail how we should be doing the alignment. It's always important to leave it 10 degrees, a little short of the final alignment. Then make sure you seal your wounds well, as Dr. Abhijit already explained to us. Once you've sealed your wounds, then you can do the final, fine tuning. So this patient then had a good result, had a refraction of minus 0.25, and the axis was well aligned. So, in conclusion, I would say prevention is always better than cure. Pre op counseling is good to set the patient's expectations. Do a careful biometry, IOL selection, and a surgical timeout is very essential to prevent any avoidable errors. The barrier to 100% success is definitely predicting your effective lens position, and also the fact that we get IOL powers only in 0.5 diopter steps. And those cases, which are high risk cases, as we discussed, we need to counsel that there could be a surprise in such patients. And we would still await to get the light adjustable lens where we can make post op refractive adjustments. Once they are available, maybe life will be simpler. Thank you so much.
Thank you, Dr. Ritu, for such an exhaustive cover. I think we've practically touched upon all points.